I'm really honored to introduce our next speaker. Our next speaker we will be bringing in is a really good friend and a huge mentor for us here at the center, Dr. Robert Horton. He'll be talking about the trauma-informed therapy and the salutogenic approach. This is from the salutogenic perspective. It is amazing that we've had a journey with us. He's had a journey with us for I think over a year. I think it was October 2020 when we started 2021 when we hopefully got in touch with Dr. Robert. Dr. Robert Horton is the CEO of Arizona Trauma Institute and the president at the Trauma Institute International. Dr. Robert has worked with and supervised multiple outpatient clinics, intensive outpatient substance abuse programs, juvenile justice programs, including service programs for adolescents, children, adults, and family. Dr. Horton works internationally with organizations to improve the delivery of trauma-informed services provided, and he's definitely a mentor for the center. He's someone who's really helped us grow and bring in all the sort of like information regarding salutogenics here to Pakistan. And I am personally a really big fan, and hopefully I'm really excited to give the floor off to him. Dr. Robert, the floor is yours.
Thank you. I'm excited to be able to visit with everybody and share a little bit about approaches to doing trauma work, and hopefully, allow people to maybe get a different perspective. So as An mentioned, he's been working with us for about a little over a year now. And one of the things that we introduced to him was the salutogenic approach to treating trauma. Arizona Trauma Institute, as an organization, we use the salutogenic perspective in all of our services. The salutogenic approach is a well-researched approach to dealing with things. It has a great deal of outcome data to support it. It's been is originally pioneered in 1968, and so we've had quite a long time to collect data on it. However, it's not all that well known in the mental health world, which is kind of unfortunate. If salutogenics is a new word for you, let me give you just kind of a brief introduction. Salutogenesis is an asset-focused approach. And I'm going to go ahead and explain that over the next, few slides, or next few minutes about what I mean by that. And then towards the end, I'll put something up on as a slide share so that you can actually see what those assets are. But in the most simplest terms, what we're doing is basically focusing on what's creating or what increases the level of well-being for someone, rather than, what we'll talk about in a minute, rather than focusing on the deficits and the problems that people have. What we're focused on instead is how do we create greater well-being for people. And it is a much more soft and engaging process for the treatment of trauma. Additionally, those that are staying current with the science related to the mental health field, I know we just heard from Dr. Khan, who's a great researcher and really, he participates in that kind of thing. The research really does not support the habits that are common in the mental health world. Since 1992, with the work of Vanderhart, we began to have evidence that going after abreactions and catharsis was actually hurting clients. However, schools all over the world that we talk to are still teaching their students to confront negative emotions and sell their students this idea that they have to deal with negative emotions in order for a person to make progress. And that's really unfortunate, and it's not well supported by the science, particularly the neuroscience that has developed over the last 35 years. Essentially, traditional models of trauma treatment, which tend to focus and I'll talk a little bit more about this in a minute, that tend to focus either on cognitive or emotions tend to underserve the trauma client pretty significantly. So let's just kind of address that for a second. Traditionally, mental health and other professionals begin working with a client and even the traumatized client from the perspective that there is something broken or damaged in them. It's kind of like, I call it the hole in the head. There's some hole in the head, and so we have to fix that hole. We have to either fill it up, patch it up, or in some way cover it up so that people can function well. The problem with that is that almost all the time you're looking at, mental health is looking at singular causes. And what that does is we bring people into the system of care, whatever that is, and we immediately begin to look at exploring their deficits and where they have shortfalls. And that doesn't seem to be, if you think about it, think about it from let's do something really simple, like a farmer. The farmer will eventually need to know what things are interfering with him having the best crop, but what's going to pay off more is helping them develop better strategies to farm rather than digging out why they aren't such a good farmer. And it's kind of that perspective in the salutogenic approach. We're looking at what we can do, what the client is capable of doing to move towards wellness. So when you start looking at this, another comparison might be, typically in a lot of our mindsets, it's kind of like we're taking a motor vehicle into a repair facility. And our question is, or our request is, please fix our vehicle. And it's doing this, or it's doing that, or it's making this crazy noise, and we're uncomfortable because of that, or it's not working the way it should. And so your mechanic strives to identify what is wrong. The process only has the mechanic focusing on what isn't working on the vehicle. The mechanic's basic assumption is that there is a cause, and that if we can fix that cause, then the car's 100, or whatever the motor vehicle is now 100%. And I think that focus on acuity and deficit has permeated the mental health world since the beginning of mental health. And we have a lot of people that approach mental health from that mechanic-like perspective, that they are looking for what's wrong and what needs to be fixed. The basic problem with that is that the areas that they tend to assume that are broken are all centered in the individual. So in the mental health world, problems are assumed to be centered either in the individual's thinking process or their emotion process. And that is the primary place we're looking for deficits. The challenge with that is that cognition, or those cognition approaches, tend to focus on what we would consider neocortex or executive functioning processes that require the employment of that executive functioning system, which is necessary, absolutely necessary, for self-reflection and self-evaluation. And so a lot of the cognitive approaches to dealing with this kind of are in this arena. Then you have the emotion-focused people that are assuming that the problem has to do with some intense emotion that is being manifested. And of course, we understand that intense emotions, particularly intense negative emotions, activate the amygdala system and activate the hormones of threat in the body, which again is a process. And what we're seeing are completely correct biological responses. Unfortunately, what they frequently leave out is that the learning history of your client, what is their history of trauma, toxic stress, repetitive adversity. If they have that kind of a significant history, the natural outcome is that they spend a lot of time in their amygdala system, because that is biologically correct, because they're always in a state of constant arousal. So the very nature of the traditional approaches of either cognitive or emotion focused approaches to dealing with trauma leave the trauma client underserved. So one of the encouragements we have in using the salutogenic approach is we can kind of step away from the burden of those two assumptions. Often when I make statements like this, therapists, counselors, psychologists react negatively, not because of what I'm saying is false, not because there isn't mountains of neurological data that support it, but more that these are things that they were taught in school, and this is what has been socially acceptable as the currency of mental health. And the mental health field tends to be a social learning system rather than a science-based learning system. And so if your supervisor does it, or your friend does it, or the therapists that have been working there have done it for a couple of 2 or 3 or 4 years, then that must be the right thing to do. And so what you find is this incredible lag between the science of this field and the implementation of that science. And I don't know what it would be in Pakistan, but I know in the US, that lag time is nearly 30 years. A lot of the things people are still being taught in their graduate counseling programs and in their psychology curriculum is 30 years behind the neuroscience of this field. So I'm not blaming anybody for not embracing this, because if they aren't kind of into research, and if they aren't kind of constantly staying in the forefront of what's new and what the science is saying, then they have to rely either on the social learning that they've done in their clinics, or they have to rely on what they learned in school. So the challenge faced when we are working with trauma clients is that a lot of the mental health world is operating on this premise of acuity, or in other words, they're looking for the busted, broken, and missing piece. And the fundamental belief that it is possible to find and then fix the deficit will then restore the individual to the status quo is what I hear over and over again. If we can just fix this, then they will be back to normal. Well, here's the problem with that. Many of the clients that have complex trauma issues don't have a single problem. In fact, most of their history has multiple things that have stressed their bodies, multiple adverse events that have created toxic stress, and they don't have any good to go back to. So this idea that if we just fix this broken part, that they will be able to return to good functioning when they weren't in good functioning to begin with is kind of a misunderstanding and a misapplication of some of the traditional methods of how we treat. What does the status quo look for your clients that grew up in a home of domestic violence and substance abuse or parental mental illness, that were constantly stressed every day in overwhelming ways, living in fear or constant shame or blame? They were bullied, and this is the way they grew to maturity. What's the likelihood that there is a good place for them to return to? So this, we have to think differently about the way we interpret and understand trauma. The idea that health and well-being come from fixing broken parts makes sense only if you're dealing with mechanical objects, such as a motor vehicle, or in the case of medicine, a broken bone. But it falls very, very short with trauma, toxic stress, and repeated adversity. Trauma tends to be environmentally contextual, multi-systemic, and is based on completely predictable, biologically driven reactions. In other words, the person that is having trauma symptoms is not generating those through some deficit in themselves. They are doing it in relationship to the environments that they are in, the multiple environments that they're in, and the multiple systems in which they are being stressed. And that's a big difference than the traditional mental health that believes that the deficit is in here. With trauma, the deficit is not in here. The trauma is almost always housed in the environmental context. And that's a really tough thing because people don't know what to do with that. They're having enough trouble kind of getting a person fixed. And so, I really liked what Dr. Khan said from his presentation, that what we want to do is get this information into the public's hands and try to see if we can't not only have mental health people be aware of this, but parents and teachers and businesses, so that we can broadly impact the environments that people are in. There is also an implicit defectiveness assumed when we are looking at the typical nosologies like the DSM or the ICD systems. What they do is take an array biologically predictable, hormonally correct behavior and responses as proof of pathology, going as far as assuming that if these responses are persistent, they must be parts of a person's character or attributes of character or personality. That's a really dangerous assumption to make, but we see it made over and over again. Again, just to make sure that I'm really clear, trauma, as we're defining it, is not about a big bad event. The trauma that creates the most problems for us is not about a single event. The trauma that is the most problematic is an environmental, multi-systemic, biological response to a person's physiology, which creates deficits in their ability to create functional meanings related to the context or environments that they operate in. And they then build neural pathways and procedural memory on how to deal with that arousal. So it is very practical, and it's much more healthy to define it this way than as a deficit in their thinking or emotions. This is just another way to think about a person's learning history. This separates trauma from traditional psychiatric understanding of mental health problems, which again assumes that the individual has the problem within themselves, because that's not where we're going to be looking. That's not what we assume. The reality is that trauma isn't about deficits in an individual. It is more related to the physiology, social, and sensory responses to the environment and social interactions of our personal histories. And that's much more approachable quite often when you take it from the point of view of focusing on what can we do to help this person develop and move forward and have greater health and well-being, than getting focused on the deficits. Because what you find, and this is fairly true in clinics that I have been in and supervised or audited, is the longer somebody's in treatment, the more diagnosis they tend to accrue, because you get more of what you focus on. If you're only focusing on deficits, then you're going to find more deficits. And that we've known that since the work of George Kelly in the mid 1950s. So this is not new ideas. So when we start looking at this and trying to make it more accessible, to be able to help people, to be able to provide for them to have an avenue to heal with greater complexity of history, then we're always looking at frequency and duration. We're looking at intensity. We're looking at environment. We're looking at, the history of the learning history of a person, not so much at the details of the bad stuff that happened to them. So what if we chose to think about it from the point of view of a salutogenic approach rather than a pathology approach? Again, salutogenesis is an asset-focused approach. And so let me share my screen with you a little bit and show you what I mean by that. And there we go. I think it went. Okay. So if you're looking at a salutogenic approach, an asset-focused approach, the sequencing of how you sequence treatment becomes really important. You always are going to focus on self-regulation first. Why? And the primary cause is they cannot regulate themselves very well. They can't access their neocortex and their executive functioning system. And almost all growth and change that is intentional and is sustainable requires access to the neocortex. It requires us to be able to function in our executive functioning system. Also, you can't problem solve well when you are in an aroused or sympathetic system dominant state. Self-regulation always comes first in the salutogenic approach. What I run into more than anything else in talking about this with people in different settings is that they were never taught how to regulate someone's system. There are a few that are somatic therapists or come out of the world of occupational therapy, or they've worked in state hospitals with highly severe cases, have had to learn how to self-regulate themselves and their client. But when we're working with trauma clients, actually we find this works with all clients, but self-regulation comes first. Next, help build the capacities that they have. You have to attune to them and recognize that they have capacities. If they've gone through the history they have and they're still walking around, then they have capacities. And you need to find them and to make them concrete and help them use those capacities intentionally. You have to help them meet their primary social and emotional needs before you even go to your model of treatment. And you have to increase the client's sense of well-being. In other words, being heard and respected. You have to help them develop a long-term view or a positive expectation of having what we call hope. And you have to strengthen their interpersonal resources and strengthen their personal resilience to stressors. This is the process we would move somebody through if we're going to trauma work with them. Now, this is the process. What are the assets? The assets we are looking at really are how do we help them thrive and be resilient? How do we help them be have self-efficacy? How do we help them develop a greater hardiness or grit? If you want to think of grit as kind of that stick-to-itness, what do they have to be able to do that to be able to do that? What does that require? And you begin to help them kind of find the times that they have done that and kind of, strengthen it. Locus of control. We want to help develop a growth orientation. Once again, a growth orientation, or that looking forward to a future in a more positive expectancy than you have now, that is hope. We help them focus on the social and emotional intelligence that is necessary for optimal healthy functioning. We help them learn or understand how to better attach and connect to other people. We focus on empowerment, learned optimism, which another word for learned optimism is the ability to have faith, coping skills, quality of life, and what does it take for them to flourish. Now, most people that I talk to in clinical settings will see these and say, well, of course, that's what we want. But they go after the deficits first. Here's my question. Why? Why do you go after the deficits first when you can go directly after these and save your client a tremendous amount of wear and tear and suffering? Somebody told me a couple of days ago, well, that's just positive psychology. No, this was actually around long before the field of positive psychology emerged. This has been around, like I said, since 1968. And the data on it is really rich, but it's so different in perspective than the traditional mental health field that it just doesn't get much playtime, though the people that practice from a salutogenic approach tend to have clients stay in treatment longer, stay, to completion. They tend to have less recidivism. They tend to be at a year after treatment are still really satisfied with the progress they made, and often there has been a significant bounce in life satisfaction even from the time they finish treatment to the year when we do the follow-up. So really, what I'm promoting with you today is give yourself some time to explore the salutogenic approach, begin to look at how it might serve the clients you work with in a more effective way. Certainly with all of the complicated challenges that you have in Pakistan that Dr. Khan mentioned and kind of did a real good job of kind of laying out, you need a system that is more holistic, more whole person rather than deficit focused, because when you find you have a lot of negative social determinants of health in your community, in your environment, and you're focusing on deficits, you're going to find it increasingly problematic to provide good treatment for trauma clients. So I hope that has given you, a good basic introduction to why we use salutogenic approaches with trauma. And I'm going to do a little cheap advertisement here and say, if you really were kind of fascinated and you want to find out more about how to effectively serve traumatized clients, I'm going to send you to the Trauma Release and Wellness Center. There, if you're wanting other information or resources, you can also reach out to our offices, and I've given you the information there. And now I think I'm supposed to do a 10-minute
Yes.
discussion.
Yeah. So thank you so much for that talk. I really appreciate that. And hopefully, if you like, similarly to how it was before, if any participants have any questions, they can type it in the chat box. We will have a limited amount of time in the middle right now, but I'm really glad to share that anyone who's interested in having a longer discussion after the end, during the end of the summit at 11 a.m. Pakistan time, Dr. Robert will be taking on and will be having a Q&A session. So anyone who wants to bring in any questions and discuss any work that they would feel that they want to share with that, looking forward to having that part as well.
Maybe they don't have any questions for me and I get to go and Roderick gets to go ahead early.
I think you're just sort of like taking everything in. Wonderful. And really sort of like, again, really appreciative as well. I think the approach is very good. And we have a question that kind of comes in, you know, so I think Arsalan is kind of asking Dr. Robert, the question is, how would which approach to treat trauma client is more effective? Then we have also a question about what's your view on EMDR therapy, and is it possible to ask Dr. Robert directly through video? Yes, hopefully at the end of the seminar at 11 o'clock, we will be able to provide that, and you can ask Dr. Robert questions directly. So I think people have a lot of questions about different types of therapies and their effectiveness.
So when we start looking at, and I'm going to play with you a little bit, the right or the most or the best treatment for trauma, that it is kind of a it's kind of a trap. We really do tell people that if they have an evidence-based model, if they have this swanky, sexy model of treatment, then they're going to get all these good results. The reality is, from all of the data going back into 1993, when Michael Lambert started doing that research, and lots of other researchers have added to that, the model of treatment only has about a 2% impact on the outcome of treatment. So why are we spending so much time focused on models of treatment? The single most powerful tool to help people change is the quality of the therapeutic alliance, which is really your ability to attach to your client. That's the single largest predictor of outcome. It's about 15 times stronger than a model of treatment. So what we're going to suggest to you is don't get worried about models of treatment. Get really good at the process of getting your client regulated. And once they're really well regulated, any model will work well. And that's, you know, if this was an EMDR conference, they would be, you know, getting me ready to hoist me up and burn me at the stake here, because, you know, people kind of unite to models of treatment like religious fervor. I have the true model of therapy here. Oh no, I have it. Well, that's all bullshit. We know that the process of moving somebody through therapy is a much more predictable of outcomes than which model you use. So I love that question, because it focuses what is so common in the mental health world. We believe if we have a great model, we're going to get a great outcome. And the evidence just doesn't support that. I don't remember the other question you asked. Your mic is off on.
Right. There was another question that come in is, what are the different types of self-regulation techniques that you use?
The one you want to ask that to will be Camilla, who'll be joining us a little later. That's her baby. And she can spend hours and hours and hours talking about that, and often does. So there are a tremendous number of them. On our YouTube page, we probably have quick examples of really quick exercises you can do. I think we have close to 30 examples. And you can just go onto YouTube and search for Arizona Trauma Institute. They're all free, and you're more than welcome to download them, use them, practice them, master them.
Wonderful. Thank you so much, Doctor, for this. And I want to just tell all the participants that anyone who has any further questions, Dr. Robert would be there with us at 11 a.m. Pakistan time. If you at that moment, you will be able to have a direct conversation with him and have a one-on-one chat as well. So if you have any questions, you can sort of like email them or you can keep them. And when we will have that session at 11 a.m., I would invite you guys to just come in and ask ask the questions directly. Again, thank you so much, Bob. I mean, I really appreciate all of this. Wonderful.
Take care.